Okay, hey everybody. So today what we're going to do is we're going to have a look at the skeletal system. So this is for your level 3, okay, personal training qualification, and this is for your applied anatomy and physiology for exercise and health exam. So we're going to go through this today, and hopefully this will give you a better insight into the skeletal system and a better understanding so that you can use that information when you're personal training, but also for your exam. So hopefully by the end of the lesson, you're going to be able to identify anatomical plane of motion of different joints, actions, and exercises. You're going to be able to identify the joint actions and the typical ranges of movement of the major joints of the body. And you're going to be able to describe the benefits and risks of weight-bearing exercise for the bones and joints. Then you're going to be able to describe the common injury risks of each of the major joints and the movements that are likely to cause them. And then also you're going to explain the common postural patterns, their associated muscle imbalances, and the problems that these can cause. And then finally, a description of the relationship between the structure and the function of the skeleton. So this is really relatable to your exercise, and you should find this fairly clear. But here we go. So question, name the 3 anatomical planes of motion. So we've got 3 planes of motion that we always use. And hopefully you're thinking in your head about what these are. You may know them already. If not, you have your frontal plane of motion. Excuse me. So this is your mirror. I think of this as your mirror. Okay. Then you have your sagittal. I don't know if it helps you, but this is stuck in my head ever since someone said it. Sagittal, shark. So if you think shark, shark's got a fin that goes like this. That's your sagittal plane of movement. I don't know why that's stuck in my head, but it's stuck in my head. So hopefully it might stick in yours and help you. Okay, and then we've got our transverse. So this is slicing through the center that you can see there. Okay, so then what you've got is your 3 axes of motion throughout that. Actually, let me go back a stage. The importance of these is that you need to be able to describe movement and exercise. And although your clients might not need to know that this is through the frontal plane, the sagittal plane, the transverse plane, we want to try and include exercises in our programming, if we relate this to our programming, that includes some of these ranges of motion. So you're not just working someone through the same plane. So for example, doing a bench press and a pull, you've got your sagittal plane of motion because they're pushing forward. You've got your frontal, okay, so lateral raises, etc. Transverse, that would be rotations, like band rotations maybe, or cable rotations. And you can include all of these, and they're ways of describing these movements, but they're also useful if you're referring on to somebody else. So if you understand these, this is the language that physiotherapists will speak in. So if you get any clients referred from a physio, or they've come from an injury and you've got some notes about them, sports massage therapists will use these as a way of describing what's going on. So they're important from that point of view. They allow you to describe emotion. Otherwise, how do you write down and describe emotion when you're assessing someone, or when you're sharing information with another trainer or someone else, what they're actually doing? So this is why these are really important. So then we come back to these axes of motion. Okay, so they're slightly different. So you imagine, a bit graphic, but a pole going through the center, a pole cutting through sideways, and a pole cutting straight down. So you've got anterior, posterior. Okay, anterior being the front, posterior being the rear. And then you've got medial, lateral, so middle and it going lateral, which is side to side, and longitudinal, up and down. Okay, so you could have a mixture. So have a look at these exercises, and in your own time, think about, perform the list of actions available in each joint, which is what we'll look at in practical sessions. Discuss the approximate degrees of motion available at each joint. So for example, at the neck, let's have a look at this just quickly before I just leave you to look at the others yourself. The neck has certain movements that it can do. Okay, so we can go this way, we can go this way. Okay, it can go down, it can go up and back, although obviously we don't advise that too much because of the small vertebrae, but sometimes you want to. Okay, back, okay, and we can kind of do a movement, a combination of all of those. All right, so you've got to think about those degrees of motion. Obviously 360 being all the way around, 180. Okay, so roughly, on my neck here, I can almost do, my neck's not great, but I can almost do a 180. Okay, I definitely can't do a 360. So think about those and think about those ranges of motion. So here is the typical ranges of motion that we can go through. And this is, as you can see, the reference below, the American Academy of Orthopedic Surgeons, a little while ago, 1983, but they have put together the typical degrees of motion that you would expect at each of these joints. So again, why is this important? I always like to try and explain to you why these things are important. Well, when you're assessing your client, when you might do their first appointment and you make some notes, you need to know how far they should be moving through these joints. Okay, so let's take an example. Elbow flexion, 160 degrees. So your bicep curl essentially. Okay, so a flexion at the elbow, we're coming all the way back to here. Okay, so 90 would be here. Okay, and then we're coming all the way back to 160. We can't quite do 180, obviously, because our top of our arm's in the way. All right, so we need to know that that's what we want. So extension like to 0, flat arm. So if you see a client that's got a slight angle like this, we know that their biceps are probably a little bit too tight. Okay, so we need to know that that is full extension. And that when they do flexion, we want them to be able to come all the way back until they're blocked by their bicep or their arm. And that will dictate. So someone with a big bicep, someone other than me, all right, that will be difficult for them to get this far. They may only be able to get to here because of the size of their bicep. Okay, so that's fine because that's a specific adaptation that's occurred. But if they can only get to here and they haven't got a big bicep, then we know that there's something wrong here with the flexion. Either the bicep's not strong enough or that the tricep is too tight and it's not allowing that full flexion. Okay, so then you can start to build up what you need to do with them as a personal trainer, and things that you can start working on and things you can highlight to them that you're going to be working on so that you can show progress later on. So that's why these are important. So it's worth bearing in mind, thinking about what the full range of motion is at a joint. Okay, so there's an activity here that we would do on a practical day. Okay, but it's something you can do on your own. Select an upper and lower body exercise, analyze the exercise to identify joint actions involved in the exercise, and the planes and axis of motion. This is a really good thing to do. If I was you, what I would do now is just pause this video, go off and find a sports person in a particular pose, whether they're shooting a basketball or something like that, and try and analyze what movements they're doing at each joint. It's a really useful exercise to allow you to see movement. And then what I would also do is try and think about this when you go into the gym. So when you go into the gym yourself and you're training, then think about what you're doing when you're pressing. What plane of motion are you moving through? Have the notes with you so you get used to it. So what am I doing when I'm pressing? What's the joint action? What sort of percentage should I be able to go through at this action? Okay, and just start to put it into practical day-to-day use, and then it will become much clearer and much more useful for you. Okay, so now we're on to looking at bone mass. And bone mass obviously is something that's important for both male and females. And the question here is, how can weight-bearing exercise benefit bone mass at different times of life? Probably if we rewind a little bit, why is bone mass important? Well, it prevents us from having breaks, trips and falls. And as you may or may not know, trips and falls are a major cause of death in the older population. Because if you fall over and you break a hip and you can't get up, then the chances are you're going to end up in hospital and you're going to get other things like pneumonia and things like that. So actually, it's quite serious to be able to maintain bone density to prevent the break in the first place. All right, and to prevent you having those secondary causes of mortality. So that's why bone mass is important, and we're seeing it decrease more and more in people at younger and younger ages. So there's been a change over time, and that's related to activity. So how can weight-bearing exercise benefit bone mass at different times of life? Well, here you've got a graph that shows you how bone mass changes through your life, and some of it is hormonal. So that can make a difference. I'm probably jumping ahead and cutting off slides in the future, but you can see here that we attain peak bone mass around the age of sort of 25, then consolidation. So we stay at that same level and then we start to decrease after about the age of 40, unless we work really hard on it. So it can be minimized. So it's by no means a complete disaster. You can see with women, we've got a menopause thing here. So when women go into the menopause, then there's a change of hormonal balance, and that can actually cause a sharper decrease in bone density. All right. So obviously that's not the same with males, but we get a decrease in testosterone. So that also causes, contributes to the bone loss. So here's a research task. If you want to pause the video at this point and do this research task, you're very welcome to. Okay. Now, let me click forward. Let me just go through this quickly. Do the risks of weight-bearing exercise outweigh the benefits? Hopefully, if you've done that research, excuse me, yes, it would. Okay, because there are risks to weight-bearing exercise, which we're going to look at later on in the presentation, and injury risks and things like that. But load-bearing exercise can be quite simple. It doesn't have to be very complicated. It can be coached. Obviously, as personal trainers, that's what we're doing. We're coaching those movements that allow more advanced weight-bearing exercise. But weight-bearing exercise could be something as simple as going for a walk. You are carrying your weight when you go for a walk. So the risk is pretty low. That's about the lowest on the risk factor. Obviously, in winter, that increases, especially if it's an older person. But, you know, then you can go right the way up to deadlifting and all of those kind of things. Walking with a rucksack. Is the outcome different at different times of life? Do the risks outweigh the benefits in youth, but not in old age? Again, I would say that in old age it's important, but maybe we need to work on some leg strength first, so that they've got a certain degree of leg strength. You can do that on something easier, safer, like a fixed resistance machine, leg press, for example. And once they've developed more strength in the legs, then some of the other free weight loaded exercises or being on a treadmill could be useful. You do have to be careful about introducing too much impact. If you've got an older age person who you think has got a decrease in bone density, obviously, because we don't want to cause stress fractures, for example. But picking the appropriate exercise for the appropriate person at the appropriate time is always going to be beneficial. But again, that's the skill of the personal trainer, is picking those exercises. Are all forms of weight-bearing exercise the same? No, they're not. Okay. Again, walking is very different from doing a very heavy deadlift or a squat. So we know that, and we know that that loading is different. So we know that they're not all the same. And we know that a deadlift for someone that's older might be better than a squat, backloaded squat, because their spine might also be starting to suffer. But again, we may want to load the spine at certain points, but again, we need to build this base of strength first so that they're capable of handling those resistances. Okay. Are there any pieces of advice and guidance that may help to mitigate risk and increase the benefits? So I think I've probably just covered that. That, you know, we've got to think about the client very specifically, the stage that they're at, their training history. Are they likely to have suffered a bone density loss? And what's the outcome that we're trying to achieve? Is it maintenance? Is it with a younger person, you know, maximizing bone density as much as we can, because we get that window to improve it? So you've got to think about all of these things. So bone mass and weight-bearing exercise. So we develop our peak bone mass in childhood. So the more exercise we can get kids out and doing, and the more, you know, weight-bearing exercise like running around for kids, that's mainly, we're not going to be doing too much resistance training with them, although, you know, once they get to a certain age, we can do a little bit. Then it's maintaining it as an adult, and then it's reducing the loss as an older adult. Okay. So these are the stages that we're trying to go through. And like I say, we want to get it as high as possible as a child, and then maintain it as an adult, and then make sure that we don't lose it as we get into older adulthood. So there's two terms that you might come across. Osteoporosis is the really common one that you'd have heard of. And that's almost at the point where it's, you know, not too late, but it's real end stage. Osteopenia is sort of the middle phase. So we're not quite there yet. So the measure of appropriate bone mass is called a T-score. And the T-score is the difference between actual bone mass and the expected bone mass. And it's measured as a standard deviation from the norm. Okay. So you statisticians out there can get involved in looking at your standard deviations. The osteopenia is a condition where bone mass is below what is expected, but not yet classed as osteoporosis, between -1 and -2.5 standard deviation. So that standard line, they're just below that by -1 or -2.5. Okay. You're not going to come across this too much, these readings or these numbers, as a trainer. In fact, I don't think I've ever come across them in terms of other than sort of academically learning about them. I haven't had anyone referred to me in that, but if you're going to go on to exercise referral or things like that, then that's what you might come across. Okay, if you're going to specialize in that area later on, this sort of stuff is going to come up more often. Or if you're getting a physio referral, or you're speaking to a physio or whatever, someone's come to you and they've said, look, they've told me I've got a decrease in bone density, etc. And then osteoporosis, significantly reduced bone mass, where bones are becoming fragile and brittle. And this is obviously where someone's at major risk, which is a minus 2.5 from standard deviation. So those are the specific terms. You may need to just have an idea of those numbers in your head and the difference between them for your exam, and it's worth committing those to memory. Okay, so the benefits of weight-bearing exercise on joints: development of increased bone mass. So we know that whilst we're in that window. Reduction of loss of bone mass, reduced osteoporosis risk, synovial fluid production and viscosity improvement. So that's a big thing. Okay, so synovial fluid in the joint. So this is the fluid inside the joints that provides movement and cushioning. It becomes more viscous. Okay, so it protects the joint better. Joints are better nourished. Okay, if I could say the word properly. Increased joint stability and strength. So you're going to get better strength and stability. That's down to strength training as well. So weight-bearing exercise. Again, think of this as strength training or running or wherever we're loading the bone. So when we're standing up, essentially, can help manage symptoms of osteoarthritis in some cases. So osteoarthritis, one of the types of arthritis, painful. Okay, and it's where you're starting to get some sort of micro cracks through the joints and things like that. Obviously, you're going to get inflammation. It can help as well, right? Because of all those other benefits. So that actually improves the osteoarthritis condition, takes some of the load off the joint as well if you're stronger through that joint. Okay, so particularly knee joints. So risks of weight-bearing exercise. So we've got to look at the risks as well, and we've got to balance the two things. So the increased risk of injury as a consequence of the activity. So obviously, let's take an obvious example. If you're jogging, there's more chance of you tripping over and falling over and hurting yourself. Okay. If you're getting someone to, we said about it earlier, back squat, and mobility is an issue, or you're starting to get osteoporosis, sorry, in the spine, then that is a risk. Okay, we don't want to cause any of those injuries. Increased risk of improper loading. So again, not having the correct technique. So arching the back as they're doing a deadlift or a squat may increase symptoms of some arthritic conditions, osteoarthritis, rheumatoid, especially during flare-ups. You have to treat these very differently. And there's specific knowledge that you need for that, which we will cover separately. But you've got to be very careful with arthritic conditions. And there are some ways of loading that work better than others. Static loading is better generally. So, but yeah, we'll cover that in a separate thing. So yeah, just be aware that obviously resistance training and load-bearing activity, especially impacts with arthritis, could be an issue. So then we've got the risks of dysfunctional weight-bearing exercise on joints. So dysfunctional movement patterns will affect joint stress and soft tissues, leading to improper joint loading and misalignment, increased wear and tear, increased injury risk, and increased risk of osteoarthritis. So as PTs, we want to make sure that people are moving in the correct pattern and that they're not going to do any damage. So we don't want to allow someone to do a bad squat. We don't want to allow them to keep letting the knees drop over their toes as they're squatting. All right. We don't want to allow them to keep dipping their knees in. Okay. So we don't want valgus knees. So they, when someone squats and their knees come in like this, we want to try and avoid that. And we want to try and develop our clients so that they don't do that. So if we notice that's happening, we might need to take it back a stage and find a way to make them strong enough to be able to hold their knees in that position, whether that's using, the bands or whatever it is, or lighter loaded squats, working on function, maybe looking at their mobility in different areas as to why they're squatting like that, what else is tight or weak that's causing that problem. And the best thing you can do right now is start analyzing your own technique and looking at yourself. So, are you dipping in with one knee slightly. You know, get someone to record you doing the squats from different angles, then you can analyze them. It's a good way you can start practicing already before you start working with clients. Okay, so this is important, because if you repetitively do those poor movements, then there's going to be a problem later on. A client may come to you with a misalignment and ask you if you can help them. Okay, again, if it's outside of your scope of practice and you're not sure, talk to other PTs and get their opinion. You know, again, do some videos. Ask your client if it's okay that you work with a friend that you know that's really good with this stuff, to see if they can help you out. Okay, it's not a weakness in you, it's you doing the right thing. Okay, so always refer on if you're not sure, or just ask someone else for advice. Okay, so we don't want to affect this, and we don't want to cause this, but this could be something that someone comes to you with. Okay, dysfunction of movement patterns, quite common. Alrighty, so posture and alignment. Improper loading in youth can lead to increased skeletal aging. So if we don't move correctly when we're younger, we've got more of a chance of moving incorrectly as we get older. And then it's harder to correct, much, much harder. If you can correct it younger, much better. But, most things we can work on. So if you're not loading the body correctly as well, then obviously that's going to affect, it's going to cause you a high risk of injury. It's going to set these postural problems in and sort of cement them in, because you're going to do them over and over again. It's going to make them very hard to break. And also, if you're not loading properly, you could be loading one leg more than the other. Again, going back to the bone density, that's going to have an impact. So we want to try and avoid that. Again, we want to educate people physically earlier on, as early as we can, to make sure that they are, they're better prepared for the rest of their life. So common injuries. In small groups, discuss bone or joint injuries experienced by members of the group. I'm sure you guys have all had injuries. I'm sure, if you're active people, unfortunately, sometimes it happens, especially if you play sport. Just working in the gym, especially if you're working effectively, is actually much lower. But it can happen nonetheless. But sport, definitely, because there's external factors. And think about those. And think about why they happened. So what we've got is we've got different categories of injury. And as a sports therapist, I see this a lot, okay? And as a strength and conditioning coach, same. So intrinsic injuries caused by forces within the body. So intrinsic, internal, think of it like that. Generally, it's these things that you see that cause injuries. So weak muscles, short and tight muscles, but just because something's short and tight doesn't necessarily mean that it's strong. Muscular imbalances. So a really, really strong chest and a really weak back can cause lots of shoulder problems. Dysfunctional movement patterns. That's something else that can cause a problem. Excessive internal force. General overuse. So the most common I come across as a sports massage therapist is overuse. People doing too much or doing it too quickly and too soon. Okay, so that can be something that happens quite often. Then you've got excessive internal force. So they've tried to turn too quickly or move too fast, and it's caused a pull or a tear. That's quite common. Muscle imbalance is less so, actually, but short and tight and weak muscles, definitely. Okay, so that's your intrinsic. Then you've got your extrinsic. This is from something outside. This is either out of your control or it's involved in the activity that you're doing. So boxing could be getting hit, obviously. Rugby, football, bad tackle, dropping your equipment on your foot, car accidents, which you may come across, people coming to you with whiplash injuries, environmental, slipping on the ice, etc., etc. So then moving on to muscle and tendon sprains, ligament sprains. Muscle and tendon strains, okay. Common causes are explosive or uncontrolled movements that are a challenge to stabilize. So if you haven't got the strength to stabilize those movements, then the chance of a muscle tear or a tendon strain are much higher. Remember, just quickly going back to muscle and tendons, tendons attach muscle to bone, ligaments attach bone to bone, okay, just to remind you of that. Ligament sprains tend to be unnatural movements. So for example, I tore my ankle ligaments a long time ago, jumping for a rebound in basketball, getting bumped to the side and rolling my ankle over. Okay, and I'm sure a lot of you have rolled your ankle. It's such a common one, but you've got the ligaments on the outside of the foot and they can get torn or overstretched. And how far they get torn or overstretched is a grade 1, 2, or 3, okay, in severity. But again, that's something you cover possibly later on, or if you decide to go onto your sports massage therapy course, then we talk a lot about injuries, obviously, in that. Then you've got, so a common injury for a muscle or tendon sprain would be a ruptured Achilles tendon. So your Achilles tendon at the back of your ankle going onto your calcaneus attaches your calf muscles, okay? That can tear all the way through, it can pull, so the rupture would be a tear, okay? Severity here, they've got grade 1, 2, and 3, so they do talk about that down here. So the percentage of tear that occurs in that tendon or muscle dictates what sort of a grade it is, okay? Like I say, with the ligament sprain, you've got inversion or eversion sprains. So like I said, on the ankle, rolling. Okay, medial or lateral collateral ligaments. So that's the knee. That's the ligaments that go either side of the knee. Okay, they can get sprained, quite common for a medial collateral ligament, MCL, because of your knee getting bowed inwards like that. Or anterior and posterior cruciate ligaments. Okay, so cruciate ligaments stop your knee joint doing this, okay, front to back. And if you're on, like, happens a lot with footballers, because they'll plant their foot and then their knee will carry on going forward, and then you're going to get, a sprain or a strain there, ligament sprains. And then again, grade 1, 2, or 3, depending on severity. So a complete tear, partial tear, or a stretch, or a very minor tear. And then we've got other common injuries. So again, these are all things you're going to come across. The most common I come across in both working with clients for exercise, so for personal training, or for massage therapy, is tennis elbow. Happens really common. Again, dysfunction, people scrolling on iPads means it happens a lot. People just with their elbow in flexion, slight flexion on a constant basis. So right now when I'm at the computer, elbows are at slight flexion. We're going to see this more and more. More people spend more time people spend on devices. So very common. Runner's knee. Okay, this is where people start getting pain in the knee when they start running. So if they're doing their couch to 5K, or they're training for a marathon and they're not building up slowly enough, again, it's coming back to that thing of, they just haven't built up slowly enough. They could get runner's knee, which is iliotibial band syndrome, okay? But quite often it comes from the TFL. So the tensor fasciae latae, which is higher up, attaches to the hip and goes into the IT band. The IT band itself is pretty tight and solid. You're not going to make much impact on that at all. But what you can impact is you can stretch, okay, the muscle that tendon goes into. And that can have really good results on minimizing runner's knee. So although the pain is in the knee, the muscle that's right up by the hip that attaches to the IT band, if you can stretch that, that can have quite a strong impact on that. So there will be a video on different stretches and therapeutic treatments that you can use with clients, because I think it's quite important. Again, common cause: repetitive overuse, overstretching. Like I say, most of the time I find it's from overuse or doing too much too quickly. Shoulder, frozen shoulder. Not usually a lot you can do about this. It's a shoulder impingement, usually develops over a period of time. Repetitive movements reduce the space between the bones of the shoulder joint, and tends to be a 6-month thing. Even with treatment, that doesn't mean they shouldn't treat, but treatment is going to take about that 6 months for it to get there, okay? And then sometimes they'll fix one side and it will jump to the other side. It just seems to be a common thing with that injury. Hopefully you don't get it. You also sometimes get it from when people are in a sling too long from another injury. So try and maintain mobility where possible. Low back pain, again, very, very common. So many reasons why this can happen. You hear very commonly people going, "Oh, it's just your glutes aren't switched on." Yes, that can be, but most of the time there's other things that are going on there, and it's a tricky one. You're going to have to spend a lot of time working around it to pinpoint it. It's probably something that's happening in their daily life, so you want to dig into that. You want to look at their sleep. How are they sleeping on their side, on their back, on their front? What they're doing day to day. Are they sitting in a chair? How's their chair? How's their workstation? There's so many things that you need to go into with this, okay? And here it says it, usually multifactorial, more than one cause. Flexing and rotating the spine has been shown to increase the risk of injury or pain. So just being in flexion all the time. So strengthen the legs, strengthen the glutes, strengthen the lower back and the core, not necessarily just the abdominals by doing stretching, but by doing things like planks and those kind of things where you're statically working the core. And that's sort of what you can hope to help with. Discuss what your scope of practice is when your client is injured. Okay, this is really important. Let me just check I'm not just jumping ahead. Okay. You as a personal trainer are not there and not qualified to fix all of these injuries. You are there to try and provide good quality exercise, not cause any harm, obviously, in the first place, to correct any movement patterns that are not as good as they possibly could be. And in some cases, like I say, do stretches and some techniques like foam rolling and things like that once you've learnt about it to help you with those things. All right. So your scope of practice is not to treat those injuries. That's to be referred on to somebody else. So when you feel like, you know, I'm always slightly more cautious. If there's something that I feel like I don't really understand, then I will refer it on. Okay. Okay. Postural patterns. Again, you can dive really deep into that, and everybody has their opinion about it. The body works most efficiently when it's in a neutrally aligned posture. Okay, so shoulders back and down. We all know what good posture should be. And again, I'll try and do a video on postural alignment and how to set people's posture. But you want to make sure that people are neutrally aligned, shoulders back and down, standing up straight, natural curve in the spine. Okay, that's what you want to try and achieve. Weight in the correct place on the feet, not knees dipping too far or too far back or too far forward. Hips, again, neutral position. And that's pretty much what will prevent a lot of pain. Okay, and you want people to be functionally pain-free. So we're never going to achieve perfect posture. Okay, it's a never-ending quest if you go after it. And there's nothing wrong with trying to achieve the best you can for your client. But perfect posture, I hesitate to say it doesn't exist, but it's, I haven't really seen it, because the perfect posture for one person may not be there for another, depending on what their activities are, what their sport are. You look at the perfect posture for a gymnast, very lordotic in the lower back, big curve in the lower back. Okay, for most people, that is not good posture. But for that sport, that's what's required. Okay, so you can see the extremes. But anything where the posture is not quite right, then that could lead to dysfunction and injury if it's particularly bad. Rounded shoulders, obviously very, very common. Okay, so define neutral posture. Okay, I think I've just kind of done that. You can see from the skeleton here. Okay, that's what we're trying to achieve, this alignment between, the ear, the front of the anterior shoulder, pelvis, through the center of the knee and down just in front of the bony process of the ankle. So we've got this injury cycle. Okay, so you've got, someone could jump in at any point of that cycle. They could have muscular weakness, which leads to joint dysfunction, which leads to neuromuscular inefficiency. So their muscles aren't quite firing right. So that's when I say, like their glutes aren't switching on properly, which then leads to injury, which then leads to a muscle shortening because the muscle's injured. Okay. So this is a little cycle that you can, obviously, someone could jump in at any stage on when they come to you, and you need to look at how can we help. If it's muscle weakness, okay, let's address that before any of the other things happen. Address that, you break the cycle. Okay, so what we're looking to do is break this cycle. Upper cross syndrome. Here we go, nearly there, guys. So very, very common. Probably the most common thing you're going to see at the moment because of mobile phones, people looking at phones, computers, poor posture, being sat down too much. So the head pokes forward, okay? Spine is hyperkyphotic, so rounding at the top of the back and shoulders. Shoulders are protracted, pulled forward. Shortened and lengthened musculatures form a cross shape, so the pectorals get too tight, the back becomes weak and lengthened. So those are all things. So it says there what muscles are shortened and lengthened. So chest shortened, not necessarily stronger, but it could be shortened. Okay, lengthened neck muscles here. Okay, you can see in the cross here it says shortened there, lengthened in the back, shortened in the front, lengthened in the front. Okay, so we need to think about how we address that. Okay, and it's going to take some work on the back muscles, the stretching of the pectorals. Okay, realignment of the neck, all right, to try and bring them into that posture. And then it's getting them to reinforce it throughout the day so that they don't lose it outside of their sessions. Then we've got lower cross syndrome. So this is the opposite. This is this gymnast posture. If you think about that as the extreme, that little rectangle there shows the angle of the pelvis. So they're really lordotic, okay? This is your Instagram model who wants to show their bottom off. So anterior pelvic tilt. Spine is hyperlordotic in the lower back, so that's not going to be good for that. Shortened and lengthened musculatures form a cross shape, all right? So again, it's the same, it's just it's lower down, it's a different issue, different tilt. So the abdominals are going to be like stretched. They might not be weak, again, if you think of a gymnast, but they might be sort of lengthened. Lower back muscles really tight, okay, because they're pulling there. So you're going to have to think about how do we address that and improve it? How do we stabilize the spine of the client when they're doing certain exercises? So I find with people with this problem, if they're pressing or they're lying on a bench, then we need to work quite hard to get them to start to tilt and flatten their spine. Static exercises like plank, if you can get them in the right position and hold it, then that will help as well. Flat back. So this is where the pelvis is just hung and tilted forward. Okay, the spine is hypolordotic, so they're kind of flattening the lower spine. They're tilting the pelvis like this. Okay, so that means that the lower back is probably quite weak and lengthened. Okay, I suffer with a bit of this. So it's working on the lower back muscles. Okay, getting that pelvis to tilt and create a natural curve in the spine. What you also find is that the hips hang forward a little bit sometimes. Sway back. Head pokes forward, the cervical spine is hyperkyphotic. So this is a bit more actually. You'll see this, it's difficult sometimes to differentiate between flat back and sway back. But you've got more kyphosis at the top. Hips, posterior lean, lumbar spine, hyperlordotic, pelvis is posteriorly tilted. You see how the hips are hung forward there. So again, this is common with people that kind of, I see it in teenagers quite a lot actually, because of the devices, but because of when they're standing, they kind of stand and lean and hang off their hips. So that's something, you know, that you want to work on. So now it's a case of analyzing the posture and looking at those. Like I say, I think what I'll do is I'll do a separate demonstration with a body so you can see me doing a postural analysis on someone and correcting posture, so that you've got something to work from. But it is really important, and it's something you can work with your clients on during the sessions, at the beginning of sessions, at the end of sessions. Okay, let's reset your posture. Okay, let's get you thinking about this. It's quite nice at the beginning of sessions. Obviously, every time they're in an exercise pose, they're going to be in a different posture. So bent over row or whatever. Some clients, if they've got some of these problems, might not be capable of that. So again, it's working up to that. Okay, so you have reached the end. Well done. Okay, that was quite a long one. So hopefully now you've got all of these different learning points that we talked about at the beginning. Obviously, you can go back through the video or you can watch it in sections. Okay, watch the first section, get those movement planes correct, then go on to bone density, and then look at the third section, which is the injury and the postural analysis. Hope it's helped. Okay, a lot of information, but like I say, feel free to go through it again in different sections. And yeah, I will see you on the next one, and good luck with the revision.